So welcome everyone. Thank you so much for joining us. Whether you're joining us live or viewing this later as a recording, we are so happy to have you with us. My name is Naomi Hoffer. I am honored to be the program manager for the Sherry Sobrato-Brisson Brain Cancer Survivorship Program. And this webinar is part of our monthly series. And the webinar series is part of our growing survivorship program that we have continued to expand over the last year and will continue to do so. Thanks to a generous grant by Sherry Sobrato-Brisson. It's my honor to have an esteemed panel of presenters here as our speakers on this important topic. Alexa Greenstein is our survivorship program nurse practitioner and was instrumental in planning this webinar. In addition to helping behind the scenes with survivorship programming, Alexa also sees patients in our UCSF Neuro-Cognitive Clinic and co-leads our monthly brain tumor support group. Jane Rabbit is the nurse manager for the Neuro-Oncology Clinic and oversees the day-to-day management of the clinic operations, including the research programs. Working closely with the Cancer Center, with leadership and other constituents, Jane helps streamline processes while ensuring safety and protocol compliance. Dr. Jennie Taylor is an associate professor at UCSF and specializes in caring for adult patients with primary brain tumors. In addition to her clinical work, Dr. Taylor is involved in several active areas of research designed to improve outcomes and quality of life for our brain tumor survivors. And Rosemary Rossi is the clinical social worker at the UCSF Helen Diller Family Comprehensive Cancer Center. We are fortunate to have Rosemary embedded in our neuro-oncology practice, where she provides education, resources, and direct emotional support to our patients, their caregivers, as well as to our entire staff. It is a pleasure to have each of these wonderful people on our neuro-oncology team at this webinar. Thank you all for being here to help us understand this topic in greater detail. And I'm very delighted to also have Dr. Suzanne Chang here to start us off. Dr. Chang is an internationally recognized leader in the field of neurological malignancies. In addition to her interest in clinical trials and imaging research, she is extremely dedicated to improving the experience of our patients and their families. Among many other esteemed titles, Dr. Chang is the director of the Sherry Sobrato-Brisson Brain Cancer Survivorship Program. It's an honor to have her here with us to introduce this topic. Dr. Chang, I will now turn it over to you.
Thank you so much. I'd like to welcome everyone to tonight's webinar and thank Naomi and all the speakers for their time and expertise. It is really hard to believe that when we hosted the very first webinar on this topic in April 2020, that we would be at this juncture. But we wanted to provide an update on the current COVID-19 outbreak, explain the available COVID-19 vaccines and what this means for brain tumor patients, review what UCSF and the Neuro-Oncology Clinic is doing to protect the well-being of patients, visitors, and staff, and share strategies to take care of your emotional health during the pandemic. Our first speaker is Alexa Greenstein, and she will provide a national and state update of COVID-19. Thank you.
Thank you, Dr. Chang and Naomi, for the lovely introduction. Welcome again, everyone, to our second COVID-19 webinar. As Naomi already mentioned, please go ahead and submit any questions you may have in the question and answer section. To start off the webinar this evening, we wanted to provide a brief epidemiology update on the novel COVID-19 virus. Since the coronavirus outbreak started in December last year, it has touched every corner of this earth. Millions of people around the world have been sick and hundreds of thousands have lost their lives to the virus. Globally, the main driver for infections and deaths continues to be the United States. The first confirmed coronavirus case in the United States was detected on January 21st, 2020, almost exactly 1 year ago. In just the few first weeks of 2021, the United States has reported record-breaking numbers of daily COVID-19 infections, hospitalizations, and deaths. According to the CDC database, in the United States, there have been more than 24 million confirmed COVID-19 cases and over 400,000 people who've died due to the virus. The pace in which the virus is claiming lives is unsettling and upsetting. In the last 5 weeks, more than 100,000 people have died. Many states continue to drive up cases. This week, California continues to be the #1 contributor to US cases, followed by Texas, New York, and Florida. California leads all states in cases, hospitalizations, and deaths. California has now over 3 million total COVID-19 cases and more than 33,000 deaths related to COVID-19 since the pandemic start. As of January 19th, the state has had 23,794 confirmed new positive COVID-19 cases, a 0.8 increase from the prior day total, and 146 deaths, a 0.4 increase from the prior day total. Throughout the country, Latino and Black people continue to contract the virus at a higher rate, and as a whole have worse and severe outcomes compared to other ethnicities and races. In California, 55% of the state's coronavirus cases and almost 50% of the state's coronavirus deaths are among Latino people. The COVID-19 pandemic continues to spotlight the long-standing health disparities on racial and ethnic minority communities. The vast majority of positive COVID-19 cases in California and across the US are largely made up of individuals 18 to 49, likely reflecting lifestyle choices. The threat from COVID-19 remains greater for older adults. The hospitalization rate and death toll continue to be heavily skewed to older adults, with about 75% of COVID deaths occurring in adults over 65. Men and women who test positive for COVID-19 are largely equal. The virus is widespread in the state. Cases have been found in all 58 counties. As of yesterday, the state is averaging 105 new COVID-19 positive cases per day, with a 15.2 positivity rate. Different parts of the state have felt the pandemic differently. Central and Southern California have been hit the most. Compared to Central and Southern California, the situation in the Bay Area has not been as dire. Los Angeles County has surpassed 1 million confirmed coronavirus cases, with over 90,000 positive cases in the last week. With the ongoing spread of the coronavirus, this feels like a very dark time, but there are some hopeful trends that indicate things are stabilizing and improving in California. One, that this past week, there have been fewer cases and deaths than the week prior, as well as a decrease in hospitalizations. ICU bed capacity is increasing in 3 out of the 5 regions, which is important since the regional stay-at-home order capacity, ICU capacity is an indicator for closures. The COVID-19 vaccine and distribution are vital in recovering and moving beyond this pandemic. Understandably, there are a lot of questions and concerns about this vaccine, the vaccine rollout, and quite frankly, the vaccine itself, which we'll touch on later on in this webinar. But on a state level, California received the largest number of coronavirus vaccines, about 3.23 million doses. Over 1.4 million doses of the COVID-19 vaccine have been administered. With the continued rollout of vaccinations, we hope this will provide much needed relief from this pandemic. I'm going to pivot now and touch on the emerging COVID-19 variants. Since the pandemic began, researchers and scientists have been studying and tracking the virus and how it evolves. All viruses carry genetic material, and when the virus tries to replicate itself, there can be errors or mutations that occur that change the genetic code of the virus. Many of these mutations often do not pose a threat to the individual that is infected or is even harmful. However, there are mutations that can affect how it spreads and make a virus more difficult to recognize, therefore fight off. Like other viruses, the coronavirus is constantly changing. There have been reports of a variant referred to as B.1.1.7 that has raised global attention. The B.1.1.7 variant is believed to have been first detected in the United Kingdom back in September. Since then, the variant has been detected in many US states, including California. Compared to other variants, the strain has many more mutations, which seem to make the virus more transmissible, making it easier to spread person to person. As of Monday night, the CDC's models show that there are 122 cases in the United States, and of those, 40 cases are in California. There is no current evidence so far indicating that this virus can cause more severe illness, increased risk of death, or will affect the vaccines. Public health officials are continuously monitoring the situation closely and working to enhance surveillance efforts. There's also another variant, L45-2R, identified in several larger outbreaks in California. We don't know much about this variant. The state is working with local and federal health departments to better understand and learn more about this variant, how it behaves, and how it might impact vaccine performance. So what do these variants mean for the pandemic? With increased transmission, it can lead to more cases and additional strain on already stressed healthcare. We need to learn more about these variants and increase efforts for more surveillance programs. Also, it further highlights the need to increase efforts to prevent and mitigate the spread of COVID-19. It is more critical than ever to stay home, wear a mask over both your mouth and nose if you leave your home, avoid crowds, socially distance, washing your hands often. It can be very stressful to keep up with the rapidly emerging news these days. In the PowerPoint, as well as a follow-up email, we've included some great websites and resources to help you keep up to date with the latest coronavirus information. Although it seems like we might be moving towards a more positive trend, we still have a lot of work ahead of us. We're hopeful with the COVID-19 vaccine and the systems that are in place, we're taking critical steps to overcome this pandemic. I'm now going to turn it over to Jane Rabbit, who will lead us in an update of UCSF's tremendous effort in controlling the spread of COVID-19 and its commitment to protecting the lives of patients, visitors, and staff. Take it away, Jane.
Good evening. Hi. So I'm going to continue from where Alexa left off on what to expect as a neuro-oncology patient coming here to UCSF and to our clinic. UCSF has implemented a comprehensive screening system that ensures our patients do not come into contact with anyone displaying COVID-19 symptoms when visiting our clinic. All patients are screened before entering any clinical building, and we've set up a separate screening clinic for patients with COVID-19 symptoms, and these patients are isolated while waiting for the test results. And all surgical patients, regardless of symptoms, are tested before being admitted. So I just updated this picture from April of last year. Some of the changes that we have done is that now between any point of contact with staff, there are these plexiglass barriers. You'll see them entering any of the buildings. You'll see them at the front desk when you're checking in. It's a little bit like an old-fashioned bank teller. You pass everything through a small opening. With the current surge that we have seen in December and January, visitors are restricted, and we will go into that a little more detail. And then these are the steps when you walk in. They have it very clearly marked that as you come in, we have a screening questionnaire. You use hand sanitizer, you take a mask, and you take a daily sticker. So our clinic and all areas of UCSF Health are prepared for your visit. And tonight we'll review how the university and Neuro-Oncology have coordinated responses to COVID-19, are trained and prepared for COVID-19, have prioritized the needs of our patients, and have restructured and enhanced the appointment process in Neuro-Oncology and in all departments at UCSF. Our coordinated response. Amongst all the departments and between the leadership, the physicians, the RNs, and the support staff across the university, we've coordinated this response. So when you're going from inpatient to outpatient, from clinic to clinic, you know what to expect, and we are consistent in our practices. We are trained and we are prepared for COVID-19. You hear a lot about PPE, or personal protective equipment. This is worn by all staff at all times while working on campus. Staff will wear both protective eye goggles or face shields and a facial mask. You and any essential visitor will also be required to wear a face mask at all times while visiting UCSF. We have prioritized the needs of our patients and all treatment options, including surgery, radiation therapy, chemotherapy, and clinical trials are available. The medical center and the cancer center leadership understand that the care of our brain tumor patients is essential. And we are enrolling in all phases of clinical trials at this time. Both therapeutic and non-therapeutic trials are available. So treatments that involve chemotherapy, radiation, and some that involve imaging only or certain blood tests. Appointments. So we will review the changes that have gone into effect due to COVID-19 that are now part of our appointment process. The screening process, the restriction of visitors, how technology has played into our changes, and space. So screening. There are several points of entry for screening. There's an online screening tool that you have access through MyChart. And one thing with COVID-19 has emphasized the importance of all patients having an active MyChart and account. By 5 a.m. the day of your appointment, you will have a MyChart message to do online screening tools to assess your exposure to COVID-19, whether you're having any symptoms to COVID-19, or whether you live with or have been exposed to others with COVID-19 symptoms. We also do a pre-appointment phone call. So our program coordinators and our research staff are assisting this process. And the day before, or Friday before a Monday appointment, we reach out to you to again do some screening assessments on your exposure to COVID-19 to help answer any questions and to assist you in the visitor restriction policies. And then on the day of your appointment, you are again screened at entrance. And that was the sign. It looks like what I showed earlier, where they'll make sure that you've been screened. They'll give you a sticker with the date of the visit. They'll ask you to clean your hand with hand sanitizers and put on the facial mask. For visitors, currently we're restricting all visitors at UCSF outpatient locations. And this actually just started in a tighter restriction as of today. Right now, we're only allowing one caregiver or visitor allowed per patient, and we must note this in the appointment as an essential visitor. So when you're doing the online screening, and most importantly, when we do the pre-appointment phone call, we need to identify that visitor because we have to notate it in our appointment notes so that that visitor will be allowed at the entrance. However, that visitor will have to comply with all the screening assessments and also comply with wearing a mask. So we really, if you have any questions about the screening or your unique situation, whether you've had some travel or you're concerned about an exposure, we just say, please call ahead and talk with your program coordinator who will be able to assist you, and then we'll get you to either the nurses or occupational health as needed. Technology is important with our COVID appointment process. Numerous appointments are now called under telehealth visits, and we have converted the majority of our visits to telehealth, 65%. Prior to COVID, it was less than 5%. It is essential to have internet access wherever you plan on having your telehealth appointment. And it's important to think about the location of your MRI imaging to the relationship to your visit time. So often patients have had MRIs here at UCSF, and if we plan ahead, although they're having a televisit with their physician, we often can accommodate you in our clinic so that you have that access. Again, we have to do the pre-screening, and you have to enter the building and do the screening, don the mask prior to coming up to the clinic. Almost every telehealth visit requires a phone assessment from our clinical medical assistant or the nurses prior to your telehealth appointment with your physician to assess your medications and any new symptoms or changes in your care. So I think a lot of patients see these numbers come up on their cell phones or their home phones and don't recognize them. So we would just say, if you see a number on the day of your visit, it is often us trying to get a hold of you to get this assessment done so that when you go into your telehealth visit, you can just start off and have the full time with your physician. Often will require you to have a current weight. So you really need a scale if possible and have vital signs. And these can be done either at home or your local primary MD's office. Space has become a different environment for us with the COVID-19. All of our staff, other than our nurses, are working an alternating remote schedule. So our physicians have been paired up in teams and are only on campus on certain days and then do telehealth visits the other days. That includes also our program coordinators and our research staff to help decrease the potential exposure to COVID-19 to our staff. We also are allowing extra space in the waiting rooms and have actually removed waiting room areas to allow for social distancing. Recently, Rosemary was reaching out to assist a patient that needed a little extra help during a clinic visit, and she wanted to see if we could wait in the first floor lobby waiting room. That does not exist anymore. That has been removed to accommodate for social distancing. Departments have also allowed for extra time between appointments to allow for deep cleaning of all the equipment and rooms with disinfectant after each patient. We are open. We are taking new patient referrals. They continue to be processed through our new patient nurse navigator. And we now are able to have video visits as an option versus prior to that, we only had telephone consults. And all our support services are available. The Gordon Murray Caregiver Program, peer-to-peer caregiver telephone support, educational and supportive planning like we're having tonight, the UCSF Brain Tumor Support Group and the Caregiver Support Group, and our medical social worker. We are all here to help support you in this journey. The bottom line is we care about you, and we are here to help you and help navigate during this really difficult time. So please just contact your health team, call us with any questions. Our main number is 415-353-2966. And here's a picture of some of our nurses and program coordinators showing off their lovely attire with our facial goggles and our facial mask. And it is important to know that during your visits here, you must wear that mask at all times, fully covering your nose and mouth. But we are all here ready to help you. And now I'm going to turn this over to Dr. Jennie Taylor, who is going to explain in depth what the vaccines are all about.
Thank you, Jane. Thank you all for joining us this evening. We really appreciate the opportunity to provide some additional information. I think that we've heard some sobering news. When we decided to do this webinar, the main focus was going to be about the vaccine, and as the surge escalated over the course of the last month or so, we realized we also needed to provide an update. So just to highlight the importance of staying nimble in this very difficult time, COVID-19 is new for all of us, including your medical providers. And as we look to the future and we look towards hope, this also continues to be a dynamic process. As Alexa alluded to, the L45R variant of the COVID-19 vaccine was just really released on Monday. And then the rollout for the vaccine is also an ongoing, evolving process with new administration today that will probably change even further. However, it is encouraging, and it's nothing short than an incredible feat of science that we have 2 approved vaccines and 2 more in process for a virus that was identified a year ago. And so it really is just an amazing testament to science and all of the volunteers who participated in the clinical trials in order to move this along and really give us an incredible opportunity to hopefully get a hold of this pandemic. So just a brief word on how vaccines work was alluded to. I'm a neuro-oncologist. I am not a virologist or an infectious disease doctor. And so I am also learning a lot more about vaccines as it pertains to all of our health, and in particular, the health of our brain tumor patients. So how does the vaccine work? So the coronavirus vaccine was generated by scientists who analyzed the gene for the spike protein on the surface of the coronavirus, and then put them into a harmless virus in order to make the vaccine. So you cannot get COVID-19 from getting the vaccine. This variant of the virus is then injected into the patient, and the vaccine enters the cells, which then start to produce the coronavirus spike protein here along the outside of of the particles. This actually prompts the immune system to produce antibodies and activate the immune system to destroy these infected cells. If then subsequently the patient encounters the coronavirus again, the immune system has been taught to recognize the virus as abnormal, and then antibodies and T cells are triggered to fight the virus. So this whole process is an educational process, teaching your immune system how to fight the virus without actually exposing you to the virus. So as everyone I'm sure knows, there's 2 vaccines that have thus far been approved in the United States, and I'm just going to focus on those 2 vaccines today. They were first approved in December of 2020 and are now being widely implemented throughout the entire country. So the first vaccine that was approved was the Pfizer vaccine. It was approved by the FDA in early December of 2020. The anticipation is that there would be 50 million doses by year end, and 100 million doses has been purchased by the United States government, with opportunity to purchase many more. The clinical trials, which we will review in a few minutes, were specific to patients older than the age of 16. So this is not a vaccine that's currently approved yet for children. And one of the particular challenges that's been faced with the rollout is that this vaccine needs to be kept frozen at temperatures near 100 degrees Fahrenheit below 0. So incredibly, very, very cold temperatures, and it's only stable at warmer temperatures for a very brief period of time. However, it was demonstrated to be 95% effective in protecting against the virus, and we'll review that again. As is the case for the 2 approved viruses, this is a 2-dose virus that's approved to be given for a 28-day booster. So you receive your first dose, and then 21 days later, plus or minus 4 days, you receive your second injection. There's a lot of debate about the benefit of receiving the first injection. What we know to be true is that after 2 injections, there's a 95% efficacy of protecting you symptomatically from the virus. The Moderna vaccine is very similar. It was approved 1 week later by the FDA, so in mid-December of 2020. There have been 20 million vaccines that are expected to be delivered by the end of 2020, and remaining to be delivered, more to be delivered in March, an additional 100 million in June. The age for approval at this vaccine is 18 years old, so a little bit older than the Pfizer vaccine, and it can be stored at temperatures above freezing. Again, very similar effectiveness, and we have no known evidence about differences in effectiveness between the Pfizer and the Moderna vaccine. It also requires 2 doses in order to provide protection, and those doses are given roughly 28 days apart, plus or minus a few days. So if you get the Pfizer vaccine as your first dose, you really cannot receive the Moderna vaccine as the second dose. I think it's important to highlight that 75,000 people throughout the United States and the world were in these vaccine studies. And particularly of note, cancer patients, which would include brain tumor patients, were excluded from the clinical trials. So the data that we're going to review today is theoretical and hypothetical, but we don't have a lot of experience with vaccinating our brain tumor patients at this point. I should also mention that AstraZeneca and Johnson & Johnson have vaccine trials that are ongoing, and we anticipate and hope that more opportunities for vaccination and different choices will be available increasingly over the course of the next few months. So are these vaccines effective? I showed you in the previous slide that these are thought to be 95% protective against symptomatic COVID-19, at least up to 4 months. So here on the right side is a curve. This is the cumulative COVID-19 incident percentage. And here on the x-axis are the days since randomization. So here in the purple line are the vaccine trial participants who received placebo. And in the orange line were the vaccine participants who received the vaccine. And you can see there's this big gap with the incidence of patients who developed symptomatic COVID-19. Now, I think it's really important for everyone to understand that the patients who were participating in these clinical trials did not receive routine COVID-19 testing. If they develop symptoms, fevers, coughs, all the things that we know are concerning for COVID-19, they were subsequently tested, and patients who had received the vaccine, only 11 in that cohort ended up being positive for COVID-19, whereas in the placebo, if you develop symptoms, 185 patients were noted to develop COVID-19. And of note, severe COVID-19 was essentially avoided completely within 120 days of randomization with the vaccine versus 30 people who went on to develop severe COVID-19 in the placebo group. So we thought this protects against different strains, and I actually made this slide before Monday when the L45R2 or L452R variant was noted. So as Alexa mentioned, this is an ongoing process that we're learning more, but it's still a small subset of the variants for COVID-19. So in general, we do feel the vaccine protects against a large number of the strains. However, what we don't know is if the vaccines protect against asymptomatic COVID-19, because again, everyone in these trials were not routinely tested for asymptomatic development of COVID-19. And therefore, as we all know, if you're asymptomatic for COVID-19, you can still transmit the virus. And so how long these vaccines are going to protect patients from COVID-19 is very difficult to know. And it's still incredibly important to wear a mask, stay 6 feet apart, and avoid crowds even after receiving your 2 doses of the COVID-19 vaccine. So what are the risks of the vaccine? Again, Alexa outlined a really challenging illness that we're all facing. There are more people dying of COVID-19 every day in the United States than cancer and heart disease and multiple other diseases combined. And so we don't know much about these vaccines. They've only been available in the United States for 6 weeks, but we do know the severity of COVID-19. And so I think as we think about the balance here, we need to be very mindful of what we do know to be true versus the theoretical unknowns. Again, I mentioned previously that the contracting COVID from the vaccine is not possible. You're not receiving a live version of COVID-19 or an attenuated version of COVID-19. You're receiving a piece of the virus in order to educate your immune system. Because you're educating your immune system, is being activated. So there are mild symptoms that commonly develop after the injection, most notably soreness at the site in the arm where it's injected, very similar to the flu shot. However, symptoms seem more likely after generating more of an immune response, providing more education for your immune system after the second dose. And in the studies I mentioned previously, the fever was actually noted in 17 to 30% of patients within a few days after receiving the second dose. And most of those fevers were less than 102 degrees, but some of them were quite high. This is self-limiting. Tylenol and ibuprofen are fine to take if you develop symptoms, making sure that you are taking it easy a day or two after having the second vaccine. But this is not you're educating your immune system against this virus, so it takes work in order to do that. And these are general inflammatory responses that the body generates in order to protect, in order to generate and fight back against the virus or against the piece of the virus. Anaphylaxis has been seen in people with a history of anaphylaxis to components of the vaccine. And in particular, one of our biggest concerns for our patients is that immunosuppressed patients, people who are on active chemotherapy or people who are on steroids, may mount less of a response with their immune system to protect them from the virus. So if the timing comes for you to, opportunity presents itself to get your vaccine and you're on chemotherapy or on steroids, please contact your neuro-oncologist and treating nursing team in order to try to optimize the timing of when you receive the vaccine to try to provide the most opportune time for immune system to be robust. So who should get the vaccine? In general, pretty much everyone should get the vaccine unless you have a known allergy to components of the vaccine or developed an allergic reaction with a severe allergic reaction with the first vaccine. And that would be like anaphylaxis reaction, not just fevers or chills or things that we mentioned before. In fact, those are common, and that means that the vaccine is in fact working. Conditions that are currently, and this is from the CDC website, conditions that are currently being recommended for vaccines include immunocompromised conditions, pregnancy and lactation. And what the actions are to help protect this population is that people are actually observed for about 15 minutes at the vaccine administrative site and in order to hopefully minimize risk of anaphylactic reaction, or monitor very closely for risk and quick response for anaphylactic reaction. People who need caution in order to receive the vaccine include those with moderate or acute severe illnesses. So if your body is fighting against something else, then potentially it would be harder for them to fight against generate the immune response that needed to protect you from the virus. And so this needs to certainly be discussed with your doctor. And then, as I mentioned previously, there's no clear contraindications aside from the possibility of an allergic reaction, of anaphylactic allergic reaction. So Jane's going to circle back around to this, but I think what are the phases for the vaccine rollout? And I know that that's why everyone's sort of tuned in this evening. So the first phase 1A, which we are 6 weeks into at this stage of the game, includes those of us who are working in the hospital, who are at risk of high risk of being in contact with someone COVID-19, and for whom we need to keep that workforce safe in order to take care not only of our brain tumor patients, but also for patients who are developing COVID-19. People who are working or living in nursing homes, which is a congregated living situation of people for whom are at high risk of getting very sick from COVID-19. And then people also living and working in assisted living facilities. Again, people, as we've all heard in the news numerous times, about difficult situations for elderly patients who are much more susceptible to COVID-19. So phase 1B is where we are now. So people 65 and older throughout the state, teachers and people working in the education or childcare in order to try to get children back to school and keep everyone safe. And then emergency service workers as well. After that, we move to phase 3. So this is, you can see there's a very clear thematic age here. So next we move up to the people who are 50 years old and to 65 years old, and then as well as people 16 years old and higher with high risk medical conditions. Now, these are very loose terms, and who exactly fits into these different categories is still being determined at the Department of Public Health level, which is what UCSF is following. And then chemical workers. And then phase 2 will be people 16 and older and sort of, if you will, the general population. And you can see these numbers are really quite high in the number of people who need to be vaccinated. And this is sort of within California. This is from the San Francisco Chronicle. So there's a lot of people with a lot of challenges of getting these people the vaccine, the process of actually getting the vaccine from the pharmaceutical companies, and then housing them safely in order to not waste any vaccine that would potentially go bad if it's at a lower or at too warm of a temperature. So a couple of very brief questions, and Jane is going to pick back up and sort of answer some of this, address some of the specific UCSF related questions, is do I need to separate getting the COVID-19 series from other vaccines? And the answer is yes. It's recommended that an interval of at least 14 days before and after any other vaccine, flu vaccine, shingles vaccine, anything along those lines, those of our patients who may be receiving vaccines for clinical trials, that there needs to be a break to give the immune system a chance to generate that, you sort of focus in on that particular virus, and then be able to mount the immune response needed to protect against COVID-19. A question that comes up frequently is, should I get the vaccine if I've already had COVID? And the answer is yes. However, it could potentially be delayed a few months. It's thought that the innate immunity that's produced from developing COVID-19 probably lasts for a couple of months. But ultimately, the thought is that may not last forever, and so it would potentially be so beneficial to get the vaccine. And is it okay if I just get one dose of the vaccine? And the answer to that is no. With the new administration that took office today, there, I think, are discussions about how to disseminate the number of doses that are available currently, giving holding back half the doses in order to be sure that there's enough doses for two doses that everyone needs in order to achieve 95% protection, or trying to vaccinate more people with the first pass. UCSF, the California Department of Public Health, and the CDC guidelines all recommend 2 doses that are required to achieve the 95% protection. And then I received my first dose on January 5th. I definitely had a sore arm for a day or so, but it was fine thereafter, and I am scheduled for my next vaccine next week. And just again, an amazing feat of science. And UCSF has really done an incredible job of rolling out the vaccines as quickly as possible. And with that, I'll turn it back over to Jane.
Hi again. UCSF currently is under that first phase that Dr. Taylor was just speaking about, and we're vaccinating within phase 1A. We have subgroups A, B, C, and D, and that is, so subgroup A are staff members that are working in the emergency room, in the ICU, on COVID floors where they know they have known exposure. Group B, then subgroup B would be in the clinic, and that's where we all fall in. And then C are non-clinical staff that are still in the clinic and have potential exposure, but low exposure risk to patients. And then D is like everybody else. So as of Monday, if you look at the very last total, 80% of all these groups have received their first vaccine. So over 17,000 staff members here at UCSF have been given their first dose. And the second dose rollout is occurring, and 20% of staff have received their second dose. So like Jennie Taylor was speaking, it's been an amazing organizational process for UCSF. I have been involved in giving the vaccines to staff members, and just within a 2-week window, it's amazing to see how much more we've learned and how much more organized we are in the process. The next series of slides are questions that UCSF have provided information for, and almost everyone has a link. So when we share this presentation webinar tonight, these are really helpful links to help answer your questions. So the first one is, when can I get my vaccine through UCSF? So UCSF is following the guidance of the California Department of Public Health and the CDC to identify patients who are eligible for the vaccine during each phase and balancing that guidance with the supply of the vaccine. As of January 15th this year, we have begun offering vaccines to patients age 65 and over, beginning with that second group that Dr. Taylor identified. It is probably important to note right now, they are providing vaccines to patients who have their primary care here at UCSF. The specialty clinics, very much like Neuro-Oncology, are working with leadership to see how we can supply a vaccine to our specialty patients. But at this time, the rollout for patients age 65 and older are for only those patients that have their primary care here at UCSF. And they want you to note that vaccine supplies are limited, so it will likely take several weeks to vaccinate just this group. They will notify you through My Chart, and they will ask you to schedule those appointments. How do I find out if my health condition would let me get the vaccine sooner at UCSF being at higher risk? So per those guidelines, we will provide vaccines for patients aged 16 to 64 with health conditions in a later state. So the phases are 65 and older, and then the next group is those with high risk health conditions. And again, here's a link to help understand the prioritization of patients receiving the vaccine. Will you be vaccinating folks at UCSF outside the age of the qualification of this upcoming round? So say I'm 40 and I would like to get the vaccine. Unfortunately, no, we here at UCSF will adhere to the CDC guidance and follow those age groups strictly. And again, here's a link to help you understand their process. How do I get on a list? We are rolling this out based on age per public health guidance and the limited availability of the vaccine here at UCSF. So there are no waiting lists and you will be contacted when it's your turn. I know that's really hard because we're all waiting to get it. I was one of the last of my group to get it, but they're not able to break protocol at this time. How will UCSF be contacting me to schedule that vaccination? So we will contact patients through MyChart or the contact information designated in your health record. If you're not on MyChart, we encourage you to sign up at ucsfhealth.org MyChart. And again, there's a link to help you know when I'm eligible for the vaccine and should I ask my care provider. I heard that the first group would include seniors above 65. Why is UCSF saying 75? Well, UCSF started with 75 and older and are expanding to 65. But as Jennie Taylor had mentioned, we're concerned about the supply. And so we want to make sure we're able to give both doses to the people that we vaccinate. Will information and side effects be provided to people receiving the vaccination? There is information available about potential side effects and other education. And here is the link to help you find that. What about immunocompromised people and children? And basically, please speak with your doctor about whether the vaccine is the right option for you. Here in Neuro-Oncology, we have numerous clinical trials, and we have been reaching out to all the sponsors of those clinical trials to have guidance and to have windows of when our patients can have the vaccine. And why is this process taking so long? The first tier of vaccines was designated for people who need to keep our healthcare system capable of taking care of others who are ill and at the highest risk of exposure to COVID-19. So here at UCSF, that's the healthcare workers and our first responders. This is an extremely large group of people. It's over 20,000, and our vaccine supply is very limited. Once the vaccine supply is more stable, we and the public health departments and the hospital will be able to offer vaccines more broadly. And today, we just received a call this afternoon for nursing staff to sign up for vaccines starting at a community level. So that's exciting that the California Public Health Department is starting to look at mass vaccination sites and are calling in nursing and pharmacy to help start vaccinating those patients. So now I am going to turn the presentation over to our amazing social worker, Rosemary Rossi.
Thank you so much, Jane, and thanks to everyone for being here tonight. Mental health in the time of COVID. What a roller coaster and what to say. I thought about taking a photo of myself on one of my down days and suggesting that to maintain one's mental health, just do the opposite of everything you see in this image. 10 months into the global pandemic, and we are experiencing a second wave. Over 400,000 Americans are dead from the coronavirus. California is at a stay-at-home order again. It's no surprise that COVID-19 has taken a toll on our mental health. As you know, a vaccine has been developed, but there's no vaccine for mental health issues. We must be proactive with our mental health, especially in these uncertain times. In our webinar last spring, we discussed the 4 M's of mental health: mindfulness, mastery, movement, and meaningful connection. When I revisited the 4 M's, it struck me at this time the 4th M of mental health, meaningful connection, might be worth focusing on today. Dr. Vivek Murthy, the 19th Surgeon General of the United States, in the midst of the pandemic, published a book in 2020 entitled Together: The Healing Power of Human Connection in a Sometimes Lonely World. Dr. Murthy diagnosed a public health epidemic of loneliness. He actually wrote the book before COVID crashed into our world and changed so much of how we interact. He found that loneliness affects people of all ages and from all walks of life. He said, disconnection from others impacts our physical and mental health and can reduce life expectancy. In January of 2020, 3 in 5 Americans reported feeling lonely. We are often ashamed of feeling lonely, but loneliness does not mean we are broken. Dr. Murthy was raised in a close-knit family, attending elite schools and later marrying, and shared that he too struggled with loneliness at various points in his life. The stereotype of a frail, elderly person alone and homebound is just that, a stereotype. In fact, recent studies suggest that the pandemic is tougher on younger people. COVID-19 has been extraordinarily stressful for everyone in different ways, due in part to the uncertain timeline and no real end date in sight, but also because at times of great stress, like now, when we might reach out to people to help lessen that stress, we are constrained by stay-at-home orders and the very real threat of infection. Think about how we celebrate and how we grieve. Most of the time, it's with people, shoulder to shoulder. Some of you may remember the famous 70s songs by Diana Ross, Reach Out and Touch Somebody's Hand. Very hard to imagine doing that today. Yet, at the center of our loneliness is our innate desire to connect. We can counter what Murthy calls a social recession and move towards a social revival with 4 strategies he researched to overcome loneliness and that sense of disconnection from others. Remember, meaningful connection is the cornerstone of mental health. So, the first strategy, make a point to spend at least 15 minutes a day. 15 minutes with people you care about. It could be anything from picking up the phone to writing a letter, Zooming with a friend, or chatting with a neighbor. Doing this consistently, 15 minutes a day, can be a powerful lifeline. And the reason the 15 minutes is so powerful is that as humans, we are wired to connect. And when we do, in a meaningful, authentic way, we get great satisfaction and fulfillment from doing it. Connection is our evolutionary birthright. The second strategy, make it count. Beware, distractions are everywhere. When you get time with others, make it count. It's a myth that we can multitask. Neuroscience research shows that smartphones are making us dumber, decreasing our emotional intelligence. When we're looking at our phones, we are not fully hearing what someone else is saying. Quality time matters. The third strategy, serve others. Search for ways to serve others. It could be as simple as checking on a neighbor, virtually reading a story to a young child, or dropping off a bag of groceries. Anything that serves another person. Service is one of the best antidotes to loneliness. The fourth strategy, embrace solitude. Solitude and loneliness are not the same. Embrace solitude. This can be sitting outside and watching the clouds or listening to an inspiring piece of music. It may sound counterintuitive, but embracing solitude and being fully with ourselves can help us get centered and ground us for future relationship building. Solitude helps increase our capacity to stay present and listen, and that enriches our connections. To listen is to love. So here it is, 15 minutes, make it count, serve others, embrace solitude. As we know, in the digital age, having 500 friends, 1,000 followers, or endless likes are not substitutes for authentic human connection. Human connections sustain us. Dr. Murthy says that at the heart of tackling loneliness is the quest to build a people-centered world powered by love. As the pandemic continues, he encourages people to rebuild and renew their lives with the principles of human connection at the core. So, as we end our time today, let us together take a breath together. Look at this slide and silently let's ask ourselves these questions. It's more important than ever that we rethink and harness the power of relationships and recognize that they are not just nice to have, but that they are necessary to have. And one last thing. Today is Inauguration Day. The word inauguration means to start something. My invitation to you is to start focusing more on authentic human connection right now and reach out to one person outside your household before the day ends and see what happens. As the inaugural poet Amanda Gorman said, "For there is always light, if only we're brave enough to see it. If only we're brave enough to be it." Thanks for your attention.
Beautiful. Thank you so much, Rosemary, Alexa, Jane, Dr. Taylor. I really appreciate it. And so inspiring. I feel like this is such an inspired day. So what we're going to do now is start reading through some of the questions. And I also want to thank Mary Destree. She's in the background. You'll see her putting some of these links in our chat box. But also, just so you know, we are recording this. So you will be getting a link to the recording. And in addition, we're going to be giving you these slides as well. So don't feel like you have to jot everything down. But I am going to go through the questions and we'll see how many we can get through before we end at 6:45. So thank you. And you can submit the questions using your Q&A function. I'm going to stop sharing for a moment. I have everyone's face up. Thank you. Okay, so I'm going to go through the questions. The first one I believe is directed towards you, Jane. So this has to do with any kind of any problem of wasting vaccines. So I'll read it out. Knowing multiple doses of vaccines are given per vial, does UCSF have a plan for unused vaccines at the end of the day to make sure that all vaccines are efficiently placed into patients and not discarded? Is there any plan to have drop-ins to receive these vaccines at the end of the day to make sure all vaccines are used?
Yes, so that has happened. One of the procedures that they do is they really have a timing system. So when a staff person or a patient checks in, then they prep that syringe so that they don't have waste. There has been times where they've had extra syringes, and what they have done is the volunteer staff who is there, who have been there, are not necessarily in that group. They are offered the vaccine. And then they have had for staff, I know, a system of drop-in where they say, they kind of put out an announcement and you can just show up.
Thank you so much. And Dr. Taylor, I'm going to address this to you. Are there any additional concerns about COVID vaccines for cancer patients who are asthmatic?
Asthmatic. So I guess one, we know for sure COVID-19 is can be very serious for asthmatic individuals. I think for the vaccine, to my knowledge, I'm a neuro-oncologist here, so I don't have all of the answers, but I think that there wouldn't be a contraindication for someone who has a history of asthma, and in fact, they may actually be at higher risk of developing COVID-19. But I think if you are asthmatic, it probably would also be best not only to talk to your neuro-oncologist, but also to circle back around with your primary care physician who's treating your asthma, and just be sure that that's that's being appropriately addressed. Thank you. It's a great question.
Yeah, thanks, Dr. Taylor. And just to tag onto that, there was a question in the chat box about, just to clarify, is having brain cancer considered high risk? Would that make brain cancer patients in the high risk category?
Yes, these are still being developed. It's a really good question. I would say our anecdotal experience for patients who have been off of treatment, and several of whom have actually received the vaccine as frontline workers themselves, knock on wood, I think have really done very well. And then I think for patients who are actively on chemotherapy, particularly some elderly patients who are living in skilled nursing facilities, et cetera, again, so far we're recommending the vaccine because, again, those are people for whom we are worried will develop COVID-19, and there haven't been any concerns. So I think as far as, quote, high risk, when we start to get to more of these larger age groups, how they're going to be dividing some of that information out, I think is something we're all very eager to find out more, not only at the CDC level, at the California Department of Public Health level, and then also within UCSF. So I think some of those things, as we get to the time where the vaccine is being rolled out in that population, we'll know a little bit more. But as Jane mentioned, we're not submitting a list of our patients who are on chemotherapy in order to kind of make sure that they're getting prioritized, but the anticipation would be probably that they would be, but the true high risk is a little bit unknown. I'd say that's true for cancer patients across the board, not just necessarily brain tumor patients.
Thank you so much. Jane, will UCSF employee ID badges have a flu dot type indication that the member has been immunized?
Good question. And yes, we have a small little dot all on our badges right now. I think Dr. Taylor might be showing hers, and it says number 1, and then we'll get a second one for number 2.
Great. Okay, thank you. And this has to do with timing for people that are on Temidor. I was told to take vaccine between day 1 to 7 of Temidor cycle. I'm scheduled for the first dose of Pfizer on day 1 of the cycle. What should I do about the second dose 3 weeks later, since I'll be then on?
I know. Yeah, this is going to be a big challenge. I think the bottom line is that we're trying to protect patients against COVID-19 and doing the best that we can. I think for people who are on chemotherapy, who end up having delayed onset of blood count problems. Temodar being a classic example, CCNU being another example. We're trying to figure this out. I think it's going to have to be a balance as to when the vaccine is, when you're presented the opportunity to get the vaccine. And it may not be that we can sort of time it perfectly, but I think following up with our nurses we're getting these questions very frequently from our nurses because our patients are asking our nurses these questions. And I think we're just trying to do that the best that we can. But knowing that there isn't a perfect answer that's going to be generalized across the board. I don't know, Jane, if you have additional thoughts there.
Well, we also have windows to those vaccines. So they have been expanded. So they're usually a plus or minus 7 days now for both of the vaccines, the Pfizer and the Moderna. So for someone on Temodar on a Pfizer, you could push it out closer to the 28 days, which would get you hopefully to a better schedule with your chemotherapy and that second injection. But like Dr. Taylor said, I think just a call to whoever is providing you with the chemotherapy. Certainly our nurses here, we're looking at those every day.
Great, thank you. And this question has to do with consent of UCSF staff. Has there been any work to analyze the consent rate for UCSF? Jane, this might be for you. Is the consent rate close to 100% of staff? Are there people deciding not to get the vaccine? And any consequences for staff that decide they don't want to get it?
So we're not at 100%. We're over 80%. Some who were offered the vaccine are now remote, so they appropriately decline the vaccine and are going to wait for the later phases. So that is reflected in that number. There is no, UCSF does not have ability to force staff to have the vaccine. But again, despite even 80% of staff getting the vaccine, we will all continue to wear our eye protection and our facial mask, possibly through the end of the year until the community has that golden 70% vaccination rate.
Okay, thank you. And I think we have time for one more question here. Knowing that COVID-19 can cause seizures, does UCSF have or know any data that suggests that brain tumor patients present higher risk for symptoms, side effects?
That's a good question. That's a good question. So no, I don't think our at least anecdotally, my experience with patients I know who've had COVID-19 have recovered. And I would also, that's my general understanding from my colleagues as well. And Jane could probably follow up with that. I will say though, as it relates to seizures, and one factor that we've talked about in one of our previous webinars is that a fever can lower the seizure threshold. And so I do think either with COVID-19 or with the vaccine, at which a fever is not uncommon, again, because your immune system's revving up and working, to be very conscientious about that and monitor for temperature and take Tylenol to keep the temperature down and therefore keep that seizure threshold risk lower. Now, that's all very theoretical. I have not heard of that happening to anyone, but just you know, as it relates to any risk of fever with any illness, we are want to be very cautious and protective of increasing that seizure risk. So so I think that would be my guidance. That was an important point. So thank you for asking that question.
Yeah, these are great questions. And again, we're going to end the question and answer right now, but we will try to follow up in an email that you'll receive with a link to this recording. You'll also when you leave this webinar, you're going to get a link to the survey. So we hope that you will take a moment to fill out the survey. It allows us to continue to plan these webinars and really do topics that are of interest to you. But I want to thank all of my wonderful panelists, my colleagues here for the great information. I'm so fortunate to work with such an amazing team. And thank all of you for joining. I want to let you know that our next webinar is on February, the third Wednesday of February, always the third Wednesday of the month at 5:30. We're going to be talking with Reagan Fedrick, who is our exercise counselor, about how to develop a home exercise program, which I think we could all use to get rid of those COVID pounds we're gaining. So I hope you can join us for that. We'll also give you a link to register in the email follow-up. So thank you again. Thanks everyone for being here, and we hope to see you again soon.